Bismillahirrahmanirrahim. Today we will discuss the topic of subfertility. Okay, basically I have taken references from the NICE guideline, the TOG article. Okay, so first of all, let us define infertility. Infertility is basically defined as the inability to conceive despite regular unprotected sexual intercourse for about 2 years. Okay, and when we talk about the UK and we discuss the heterosexual couples, the incidence is 17 to 18%, and if we talk in ratio, that is about the 1 to 7 in ratio. Now, what are the causes of subfertility? We have different causes. Sometimes male is involved, sometimes female is involved in the cause. Okay, so unexplained infertility, in which we don't have any specific male or female cause, that is responsible for 25% of the cases. Later on I will discuss with you the talk article about the unexplained subfertility as well and its management. Now in relation to the female, we have about 50% causes. Like you can say in 25% of the cases we have ovulatory disorder. In 20% of the cases in female we may have tubal damage. In 10% of the cases in female we have uterine and peritoneal disorder. So overall in female we have the 50% causes. Now, what are the male factors? Means how much percentage is responsible for the male subfertility. Factors in the male causing infertility is 30%, means 50% according to the new TOG article. Okay, and it is also very important to note that in about 40% of the cases both male and female are involved. Okay, and uterine endometrial factors, gametes or embryo defects, and pelvic conditions such as endometriosis, these may also play a role. Okay, so there are different factors which are responsible, and each and every factor play its role, but that is just the overall figure which has been found by the researchers, that this much person is responsible for subfertility. We may have certain other causes that are included in the unexplained infertility causes. Okay, so what initial advice we have to give to the people concerned about delay in conception? Okay, we have to give advice that not every couple conceive as soon as possible within 1 year. Means about 80% will conceive within 1 year, 20% will not conceive within 1 year. Okay, and which among the 80% means what are the features of those patients who conceive within the first year? Those are the couple in which the woman is under the age of 40 years and they do not use contraception and have regular sexual intercourse. Okay, so it means that if the couple comes and the woman is above the age of 40 years, or they might have used any method of contraception, or they do not do regular sexual intercourse, so we can't include them among the 80% category. Okay, 80% are those who fulfill this criteria. Okay, and also it's very important to tell, if 1 year has passed, we can tell that those who do not conceive within the first year, about half will do so in the second year. Cumulative pregnancy rate of 90%. Okay, so up to second year we may have about 90% of the couple who has conceived. Okay, so that is very important to tell to the patient. Okay, and certain information should be given to the couple or to the people who are using artificial insemination to conceive, or who are concerned about the fertility. Okay, we will tell that over 50% of the women over age will conceive within the 6th cycle of intrauterine insemination. Okay, so there is a group of couple who use IUI. IUI is very common nowadays, and the IUI gets failed. So what we have to tell them? We have to tell them that not every patient will conceive as soon as possible with IUI. Means after 6th cycle of IUI, only 50% of the women will conceive. Okay, and if they do not conceive within the 6th cycle of IUI, about half will do so in the further 6 cycles. Cumulative pregnancy rate of 75%. Means if she undergoes about 12 cycle, she will have pregnancy rate of 75%. So these figures are very important. Okay, we have to tell to the patient, and in exam questions come related to these percentages about these number of cycles. So it's very important for you to memorize these figures and percentages. Okay, now is there any effect of the sperm quality on conception? That is also very important. Okay, not every sperm has ability to cause conception as soon as possible. Okay, because the fresh sperms and the a healthy male sperm have got more ability of conception as compared to old thawed sperms. Okay, so what information we need to give to the patient? Inform the patient, inform the people who are using artificial insemination to conceive and who are concerned about fertility, that using fresh sperm is associated with a higher conception rate than the frozen thawed sperm. Okay, if they use the fresh sperm, the fertility chances are higher as compared to the frozen thawed sperm. Okay, and however, intrauterine insemination using the thawed sperm is associated with higher conception than intracervical insemination. Okay, so here the importance of the intrauterine insemination is given. Okay, that is intrauterine insemination. If we talk about intrauterine insemination, and in that even we use the frozen thawed sperm, that will carry the higher conception as compared to the case when we are going for the intracervical insemination. Okay, so these figures are very important to note. These points are very noteworthy. Okay, now sometimes the woman might ask about the frequency and the timing of the sexual intercourse or artificial insemination. Okay, to them we have to tell that people who are concerned about the fertility should be informed that the vaginal sexual intercourse every 2 to 3 days optimize the chances of the pregnancy. Okay, so if they do intercourse on alternative day or even after 3 days, that will carry higher chances of the pregnancy. And people who are using artificial insemination, we have to tell them that we need to time out their artificial insemination around the ovulation. At the time of ovulation, we need to time out the artificial insemination in order to maximize the chances of the conception. Now, alcohol has very negative effect upon the pregnancy, and we have to ask not only to the female but also to the male partner to reduce the amount of alcohol intake. Okay, so how much alcohol is allowed? That is for those group of people who use alcohol. Okay, a woman who are trying to become pregnant should be informed that drinking no more than 1 to 2 units of alcohol once or twice per week and avoiding episode of intoxication reduce the risk of harming a developing fetus. Okay, so no more than 1 to 2 units of alcohol once or twice per week. Okay, so that will not only increases her chance of conception but also minimize the risk to the developing fetus, because alcohol intoxication can cause a lot of problem in the developing fetus as well. And the male should be informed that if he uses 3 to 4 units of alcohol per day, that is unlikely to affect the semen quality. Okay, so increasing the amount of alcohol more than 3 to 4 units per day is likely to affect the semen quality. Okay, now what is the effect of BMI? Not only obesity but also low birth weight has profound effect upon the fertility. Okay, so we have to give advice not only to the overweight but also to the woman with a reduced weight as well. Okay, women who have body mass index of 30 or over should be informed that they are likely to take longer to conceive. Okay, they are likely to take longer time to conceive as compared to those with a normal BMI. And women who have BMI of 30 or over and who are not ovulating should be informed that losing weight is likely to increase the chances of conception. Okay, so if they are overweight, then the advice should be given that they should reduce their weight. And women who have BMI of less than 19, who have irregular menstruation and who are not menstruating, should be advised that increasing the body weight is likely to improve the chances of conception. Okay, and when to refer a woman: offer earlier referral to specialist consultation to discuss the option for attempting conception, further assessment and appropriate treatment where the woman is age 36 or over and there is a known clinical cause of infertility or history of predisposing factor for infertility. Now, menstrual cycle. We have to consult that they are likely to be ovulating. We have to offer serum progesterone in the mid-luteal phase of the cycle, 21 to 28 days, to confirm ovulation. And BTT is not recommended for ovulation, means basal body temperature is not recommended. That is in case of the irregular cycle. And those women who have got irregular cycle, okay, women with a prolonged irregular cycle, depending upon the timing of the menstrual period, the test needs to be conducted later in the cycle, for example 28 of 35th day, and repeated weekly thereafter until cycle start. Meyer gonadotrophins as well. Okay, now PID following HST. Up to 4% of the cases develop PID. Both doxycycline and azithromycin are effective prophylactic against the chlamydia. And semen volume, this is very important chart. I have taken this from the EBM book. Okay, so the lowest reference range is 1.5. The total sperm number is 10⁶ per ejaculate, and on the average it is 39, 33 to 46. You have to remember this. Sperm concentration, this is different from the sperm number, okay, because the sperm concentration 10⁶ per ml is the concentration of the sperm in per ml of the sperm. Okay, that is 15, and the range is 12 to 16. Progressive mortality percentage is 32, range is 31 to 34. Sperm morphology normal percentage is 4, 3 to 4 is the range. Vitality live spermatozoa percentage is 58 and the range is 55 to 6 to 3. pH of more than 7.2. Okay, now what are the causes of the abnormal parameter on the semen analysis? Like when we talk about the semen volume, the low volume causes include retrograde ejaculation, this obstruction, androgen insufficiency, and incomplete collection. Now, when to repeat semen analysis? If we have abnormal semen, we have to do confirmatory test after 3 months. And if we have azoospermia or severe abnormality, we have to repeat as soon as possible. That is very important. Okay, now this chart is very important. Use one of the following to measures to predict the likely ovarian response to gonadotrophin stimulation in IVF. Okay, because exam questions come related to this. Okay, so there are basically 3 numbers, like 3 values, like total antral follicle count, anti-Mullerian hormone, follicle stimulating hormone. Anti-Mullerian hormone are less than or equal to 4 is responsible for low response and greater than 16 for high response. An AMH of less than or equal to 5.4 picomole per liter for low response and greater than or equal to 25 for higher response. FSH greater than 8.9 for low response and less than 4 for high response. Another 2 like total antral follicle counts greater than 16 for high response and AMH greater than or equal to 25 for high response, but in FSH less than 4 is responsible for high response. Okay, Classification of ovulatory disorders is very important. Exam questions come related to this. We have basically 3 groups. Group 1, which is responsible for 10% of ovulatory disorder. In that, basically we have problem in higher center, like hypothalamic pituitary failure, hypothalamic amenorrhea, or hypogonadotrophic hypogonadism. In type 2, like 85% of ovulatory disorder, we have hypothalamic pituitary ovarian dysfunction, which is predominantly PCOS syndrome. In group 3, 4 to 5% of ovulatory disorder, there is ovarian failure. Okay, so yes, this I have already explained to you. Okay, now type 1 ovulatory disorder, how to do management of type 1 ovulatory disorder. First of all, we have to do lifestyle modifications like increase body weight if BMI less than 19, or moderating their exercise level if undertaken high level of exercise. Okay, so in type 1 ovulatory disorder, basically it's a hypothalamic pituitary disorder, hypothalamic amenorrhea, or hypothalamic hypogonadotrophic hypogonadism. So in that case, if the BMI is responsible, then we have to ask the patient to optimize the BMI. Okay, and as we have the lower gonadotrophic level in that, so pulsatile GnRH or LH2 cause ovulation. Offer the woman with group 1 ovulation disorder pulsatile administration of gonadotrophin releasing hormone or gonadotrophin with luteinizing hormone activity to induce ovulation. Okay, now when we talk about the type 2 ovulatory disorder, we may have different treatment regimens like ovulation induction by clomiphene citrate plus minus metformin. Okay, basically in type 2 ovulatory disorder, we have the problem in the ovarian level as well, hypothalamic pituitary ovarian dysfunction, predominantly PCOS. Okay, so how would you treat ovulation induction by clomiphene citrate plus minus metformin? About 15% of women are found to be clomiphene resistant. This is also important figure which needs to be remembered for exam. And for women who are taking clomiphene citrate, we have to offer ultrasound monitoring during at least the first cycle of treatment to ensure that they are taking the dose to maximize the risk of the multiple pregnancy. For women who are taking clomiphene citrate, do not continue treatment longer than 6 months. Inform about the side effects of the metformin. Now, what is the mechanism of metformin? Okay, first of all, desensitize ovary so that the clomiphene will have better effect and only one ova will be activated. That is the effect of the metformin. Like why metformin is given along with the clomiphene, basically the metformin desensitizes the ovary. Okay, so that is very important. Okay, so important figures are that 15% of women are clomiphene resistant, and those women who do not who do not conceive with the clomiphene, treatment should not be given longer than 6 months. 6 months figure is very important. Okay, now in women with the WHO group 2 ovulation disorder who are known to be resistant to clomiphene citrate. Okay, as we have told you that 15% of the women are clomiphene resistant in type 2 ovulatory disorder. So what we have to do, we can offer the choices of laparoscopic ovarian drilling or combined treatment with clomiphene citrate and metformin if not already offered as a first line treatment. Okay, so either go for laparoscopic ovarian drilling or we can combine clomiphene citrate to the metformin. Gonadotrophin, okay, human menopausal gonadotrophin, urinary FSH and recombinant FSH are equally effective. Now, what is the role of adjuvant growth hormone? Is there any role of adjuvant growth hormone? The use of adjuvant growth hormone treatment with the gonadotrophin releasing hormone agonist and or human menopausal gonadotrophin during ovulation induction in the women with PCOS who do not respond to the clomiphene citrate is not recommended. Not recommended because it does not improve the pregnancy rate. Okay, so that is why whenever we treat the patient in our clinical setups in hospitals, we do not go for adjuvant growth hormone. Okay, because it's not proven in the clinical trials. Okay, type 3 ovulatory disorder, as we have told that it is somewhat similar to that of the ovulation failure. Okay, so let us have a look at 4 to 5% of ovulatory disorder. We have the ovulation failure, so that is the type 3 ovulatory disorder. So what we have to do, we have to reassure the patient and we can give the option of IVF with the donor egg. Now let us talk about the different techniques of assisted reproduction. First of all, IUI, a very commonly used technique all over the world, and the success rate is 8 to 16%. Okay, means it hasn't got much higher success rate. 8 to 16% is the success rate, and we need to tell this figure to the patient so that after 1 or 2 IUI cycles she doesn't get depressed. And as I have told you before that in order to get cumulative pregnancy rate of 75%, she needs about the 12 cycles. Okay, so what are the indications of IUI? It's very important to know about these indications, because when we solve the MCQs of the exam, we come across the different options given in the questions like IUI, IVF, ICSI. So what we have to choose under what circumstances? Okay, like we have to know about these indications. Consider unstimulated intrauterine insemination as a treatment option in the following group as an alternative to vaginal sexual intercourse. Okay, so if by this we come to know that if the woman is having certain problem with the vaginal sexual intercourse, IUI is the preferred treatment. Okay, women who are unable to or would find it difficult to have vaginal intercourse because of the clinically diagnosed physical ability or psychosexual problems, who are using partner or donor sperms. Okay, if the woman is using partner or donor sperm and they are finding it difficult to have vaginal sexual intercourse, then IUI is preferred technique in them. And if the people with a condition that requires specific consideration in relation to the method, for example sperm washing, where the man is HIV positive, in that case also IUI is a preferred technique, and women in the same sexual relationship. Okay, so these are the different indications. Okay, first of all, those who are unable to do vaginal sexual intercourse, secondly HIV or other infections, and thirdly in the people who are in the same sex relationship. We have to memorize these indications because in exam questions these indications are given. Now, what are the chances of IUI technique success? I have already told you in the previous slides that if the woman is under 40 years of the age, about 50% will conceive within the 6 cycles. Okay, and those who do not conceive within the 6th cycle of IUI, about half will conceive within the next 6 cycles, cumulative pregnancy rate of 75%. Okay, and who should not be offered IUI? This is also very important. Not every patient is a candidate for IUI. So for women with unexplained infertility, definitely if the fertility is unexplained, IUI will not work. And if the woman is having mild endometriosis or mild male factor infertility, who are having regular and protected sexual intercourse, if these things are present, then IUI will not be suitable. Okay, and it's also very important that do not routinely offer IUI either with or without ovarian stimulation. Exception circumstances include, for example, when people have social, cultural or religious objection to IVF. Okay, if the patient is having objections to IVF, then do not routinely offer IUI. Okay, okay, so we do not offer IUI in routine except in this situation. Okay, exceptions are this: if the woman has a religious or cultural objection to IVF, then we can go for IUI. Okay, and other circumstances, when there are certain other circumstances that patient rejects the IVF, then we can go for IUI as the primary technique for infertility. Otherwise, in most of the cases after IUI, you have to go for IVF. Okay, so IUI should not be recommended as a primary technique. Okay, advise a woman to try to conceive for a total of 2 years. This is included up to 1 year before fertility investigation, before IVF can be considered. Okay, so this is a sort of another indication for contraindication for IUI, like if they do not conceive within the 2 years, then we can offer IVF. Now we have to define the male factor infertility. Okay, this term is used extensively in the practice and in the literature. However, no formally recognized definition is currently available, but the WHO defines it as when 2 or more semen analyses have 1 or more variable below 5th centile. Okay, this 5th centile figure is very important. Okay, so if we have 2 or more semen analysis having 1 or more variable below 5th centile, this is defined as subfertility. Okay, the effect on the chances of subfertility occurring on naturally through the vaginal intercourse within the 2 years would be similar to the people with unexplained infertility or mild endometriosis. Okay, so these are very important points. Now, IVF, in what cases we have to offer IVF, or what are the prediction of IVF success? Okay, in which group of the couple this IVF technique is very much successful? First of all, female age is very important. Optimal age is 23 to 39 years, and number of the previous treatment decreases with the previous cycle. Okay, and previous pregnancy chances increases with the previous history of the live birth with IVF. Okay, and if the BMI is between 19 to 30, not less than 19, not more than 30, then that is ideal BMI for IVF. And if the woman avoids alcohol, smoking, and caffeine, like less than 1 unit alcohol, increases the success rate. So these are very important points which increase the likelihood of success of the IVF technique. Now, criteria for IVF cycle. A full cycle should include 1 episode of ovarian stimulation and the transfer of any resultant fresh frozen embryo with or without ICSI. Okay, so when the age is less than 40, there are certain points related to less than 40 years of age and certain points related to the age 40 to 2 years. Okay, so if the woman's age is less than 40 who have not conceived after 2 years of the regular unprotected intercourse or 12 cycle of artificial insemination where 6 or more IUI, offer 3 full cycles of IVF with or without ICSI. Okay, so if the woman reaches the age of 40 during the treatment, complete the current cycle but do not offer the further cycles. Okay, so after 12 cycles of IVI, we can offer 3 cycles of IVF if the age of the woman is less than 40 years. But if woman reaches the 40 years, then do not offer the further cycle if she has already got these cycles, this 12 cycle of IUI and 3 cycle of IVF. But if the woman age is 40 to 42 years who have not conceived after 2 years of the regular unprotected intercourse or 12 cycle of artificial insemination where 6 or more are by IVI, offer 1 full cycle of IVF. Okay, here we're offering 3 full cycle, but when the age of the woman is 40 to 42 years, we are offering 1 full cycle of IVF with or without ICSI, provided the following criteria is met. They have never had previously had IVF treatment. Okay, if they previously had IVF treatment, we cannot even offer this 1 full cycle. And there is no evidence of the low ovarian reserve. If there is evidence of low ovarian reserve, we cannot offer this 1 full cycle of the IVF. And there has been a discussion of additional implication of IVF and pregnancy at this age. Okay, so there should be a discussion. Now, how many embryos can we transfer in IVF? Okay, number of embryos transfer if we have the first cycle, like age of the woman is under 37. Okay, and we have the first cycle, we have to transfer single embryo. But if it is the second cycle, age is under 37, we can offer single top quality embryo or 2 embryo if no top quality is available. Okay, either single top quality. Here we are just offering single in the first cycle, but in the second we have to offer either single top quality or 2 embryos if no top quality, and in third we can offer 2 embryos. Okay, 2 embryos we have to offer in the third cycle. But when the age of the woman is between 37 to 39, in the first cycle we have to offer this thing. The second step will be in the first step. here in the age 37 to 39, like a single top quality or 2 embryos if no top quality is available. In the second cycle, same thing, like single top quality embryo or 2 top embryos if no top quality is available. And in the third cycle, we have to offer 2 embryos. Okay, now when we talk about the age 40 to 42 years, in the first cycle we have to offer double embryos. Okay, now what is the maximum dose of FSH per day for ovarian stimulation in IVF? Okay, the maximum dose is 450 international unit. ICSI is very important. The live birth rate following ICSI is 25 to 30%. Okay, that is very important as compared to IUI when it was 8 to 16%. Okay, in IUI the live birth rate is 8 to 16%, whereas in ICSI the live birth rate is 25 to 30%. Okay, so it has got higher success rate. Now, what are the indications for ICSI? The recognized indication for ICSI includes, first of all, severe deficit in the semen quality, obstructive azoospermia, non-obstructive azoospermia. Okay, and in addition, treatment by ICSI should be considered for the couple in whom previous IVF treatment has resulted in the fail or poor fertilization. Okay, now donor inseminations. In certain condition, we have to go for donor insemination. Okay, if there is no contraindications from religious or social perspective of the patient. Okay, so what are the indication of obstructive azoospermia, non-obstructive azoospermia? So if we have azoospermia, then we have to go for the donor insemination, or when there is severe deficit in the semen quality in the couple who do not wish to undergo ICSI, and where there is a higher chance of transmitting a genetic disorder to the offspring, where there is a higher risk of transmitting infectious disease to the offspring or woman from the man, and severe rhesus isoimmunization. So these are all the indications of donor insemination. Now, oocyte donation. Sometimes we just go for complete oocyte donation, not for the sperm donation, but oocyte donation. So what are the indications? The use of oocyte is considered effective in managing fertility problem associated with the following conditions, like premature ovarian failure. Okay, the woman has got failed ovaries, and gonadal dysgenesis including Turner syndrome, bilateral oophorectomy, ovarian failure following chemotherapy or radiotherapy. Now, what are the management according to sperm count? If less than 5, we have to go for ICSI. If it is 5 to 10, we have to go for IVF. If it is 10 to 15, we have to go for IUI, and more than 15, spontaneous conception. Okay, so first of all, we have to go for the semen analysis. Okay, so if we have the normal sperm, we have to go for female investigation, and abnormal, repeat.